Okay, hello everyone, and thank you for joining us on this wonderful Tuesday. We are excited to have another session in our series focused on AI-enabled digital health services. Today, we are thrilled to bring Organizational Governance of AI, brought by Alifia Hasan.
Hi everybody.
Great. So a few things before we get started. Attendees have been muted and camera is off, but we are going to encourage you. We're going to open up the chat and the Q&A to submit your questions, to submit your comments, and feel free to interact with us. We'll also share some links in there, so be sure to check out the chat and use it. Say hello. And you can change your view if you'd like to see all of our speakers or gallery view. Today's session is going to be recorded, so if you have to hop early or want to share your learnings from today, we will have the video and recording available on YouTube and on our website soon. As a reminder, today's session is for informational purposes. CTRC does not provide legal advice, and we have no relevant financial interest, affiliation, or arrangement with any products or services that may be mentioned during today's session. And I will do one quick reminder also. We have an AI webpage available now on caltrc.org. Here you can find recordings of all of our previous sessions in this series, as well as some great resources curated all about AI-enabled digital health services. So please check out the webpage for more information. Now I will hand it over to our moderator for today, CTRC's Executive Director, Sylvia Trujillo.
Thank you, Hasan. Really appreciate the opportunity to have you all here. I just want to underscore a few points before our presenter launches into a really comprehensive and I think critical in terms of timing and presentation on governance. So just to underscore a few items about CTRC's approach to all digital modalities, including AI-enabled. At the center, we really emphasize the importance on equity for both underserved and rural communities. And we look at sort of the four legs of the stool. Of course, safety is first and foremost. We're also looking at effectiveness and efficacy of the modality, not just in the narrow sense of the intervention, but actually what that looks like in the context of implementation to drive quality and improved outcomes. We also look at sustainability for rural and underserved communities and their providers and patient population. So this often entails looking at things like payment and coverage. And then last, how do we get to scalability? In the next slide, we also have some key questions that whether it's telehealth or remote patient monitoring or digitally enabled applications, clinicians in particular, and there's an analog for patient populations is sort of a reprise of those four items we talked about. Is it effective? Is it safe? Is it covered? What is the liability risk? And what kind of infrastructure do I need? And will it work in my practice with my patient population? So part of this series, we've touched on elements of these. And certainly as you think about governance, you should think about, as the presenter runs over these issues, how does that fit into this? And we'll have some more tools to help support that. Now we'll move to the next slide. So at the end of the day, for AI in particular, there are some very specific questions that we are really urging you as you are listening to our presenters to think about. What are the intended applications for this tool? What is the patient population that's going to be served? What are the clinical problems? How is it tested and validated? What are the personnel, procedures, policies, and processes we should have in place, and how will it be monitored over time? And so you're going to see that Alifia is going to cover many of these topics, but you'll also have a toolkit, a cheat sheet, as it were, to really think about these things when you're applying them in practice. And so now, without further ado, I'm going to hand this over. Oh, I forgot one item. I want to emphasize with Dr. Mark Sendek and Alifia right here, we have been really pleased to have this partnership with the Health AI partnership and collaboration in bringing this 3-part series, and you can find out more from the prior 2 presentations at our YouTube channel. And so without further ado, I'd like to hand this over to Alifia to talk about the work that she's done in this space, and then we'll have Mark do a little bit before the presentation. So with that, Alifia.
Hi, everybody. Thank you so much for having us over. I'll do a quick introduction and then share my slides. So I'm Alifia Hasan. I am Innovations Portfolio Manager at Duke Institute for Health Innovation. And I work with Mark Sendek, my colleague here, and Ji Young, who's I think in the audience as well, and rest of the DIHI team to really understand the best practices around AI adoption and workflow integration, and also understand what are some of the governance practices and what are some of the equity assessment procedures that we can follow. And we do this work by really talking to different practitioners across the nation, conducting interviews, quality assessments, qualitative research, and surfacing those best practices. I'm very excited to join today. Mark, would you like to introduce, and then I can jump into the presentation?
Sure. Hi, everybody. My name is Mark Sendak, and I work with Alifia at the Duke Institute for Health Innovation, did my medical degree and health policy master's at Duke. Was very fortunate to meet Sylvia during her tenure at the American Medical Association many years ago, working on AI policy, and we're thrilled to be able to help bring our learnings to this audience and support care delivery settings across California. So one thing to flag is that I will be in transit on the end of this call. I do a school drop off, so I'll be on the phone and we'll fall off video. But
sounds good. All right. Okay, let me see if I can share my screen really quick. And let me know if you're able to see my screen fine. Okay, sounds good. So today's talk will focus on organizational governance of AI, and this is summarization of all of our work with Health AI Partnership, which is a collaborative network where we try to understand best practices in AI adoption, as well as internal work and experience at DIHI, implementing AI projects in health system. So some of the learning objectives for today are, I'll start by just defining basic terminologies around health AI in general. Some of these you might be very familiar with, but it's good to just start with the foundations. Then I'll go over the common stages and decision points that healthcare organizations need to navigate throughout the AI product lifecycle, what are some of the best practices around those decision points, and specify organizational capabilities and processes required to govern, and some of the technology, people, process, infrastructure needed. So this is the general agenda. I'll quickly spend a couple of minutes describing who we are at DIHI, some terminologies, then we'll go over into Health AI Partnership, the key decision point framework, and the governance. So Duke Institute for Health Innovation, our mission is to catalyze innovations at Duke. We do this by really focusing on innovations by design. So we work with frontline providers and in developing deep understanding of their needs and environment. And then we identify their pain points, desired outcomes, analyze all possible solutions, map out the workflow, and implement solution in partnership with the frontline clinicians and care providers. These are the 4 domains of innovations that we follow. So first and foremost, we serve the Duke clinical care teams on the front lines. So we have very heavy focus on practicality of implementation and workflow integration. We leverage a wealth of data, digital data that is generated here in the health system. So we've built over the years infrastructure and ecosystem to harness the digital data and co-develop technology based on that. we also have an education mission. So we train the current and future leaders across the healthcare organization through internships and fellowships at DIHI, and help them get trained for the use of AI in healthcare settings. And the most recent edition is understanding best practices for AI lifecycle. Okay. Sorry, got stuck. Okay. All right, here we go. So this slide shows we run an RFA competition, so which is like an innovation competition every year. And this slide shows the topic for this year's RFA, which was on generative AI and large language model. And this is the one way we source best practices. And I think I missed one slide over here, which is what I was thinking. And this is our approach to innovations. So this slide shows we follow two major approaches to innovations. The one on the right-hand side shows the DIHI Innovation Jam, which is like a Shark Tank style innovation competition where the focus is on what are some of the technologies that are coming through various university schools and that could be commercialized. On the left-hand side is where we use top-down and bottom-up strategy as part of the RFA project, where we define a strategic theme for the year and source innovations and problems from the frontline clinicians, and then run those projects for over a year to develop solutions. We went through this slide. DIHI has a wide spectrum of value creation. So we focus on projects that involve tech infrastructure, research and dissemination, education and training. We are also agnostic to care settings or disease type and focus on outpatient as well as inpatient projects. Now we'll go into some of the terminology. So when I joined DIHI about 2 years ago, I was very interested in technology and emerging technology in healthcare space. I had experience in healthcare for about a decade, but I didn't have any formal training around AI and ML. So when I started, I was provided this introductory lecture by one of my colleagues, which was really helpful for me to like have some level setting on AI and ML. And I really like one of the slides that they use because it shows that AI ML basically is statistics and a lot of statistics and mathematics dressed up in different ways to call it machine learning and artificial intelligence. So this is helpful to like, be less overwhelmed. So now what is AI? So in a broadest sense, AI refers to machines that can learn, reason, and act for themselves. They can make their own decisions when faced with new situations the same way humans can. So basically they're looking at a large amounts of data, understanding that data and using statistical models, trying to make sense and predict the future predictions. So what AI is like, you can take some inputs and then analyze it and then provide some predictions the way a human would. What is machine learning? So machine learning algorithms use statistics to find patterns in massive amounts of data. So machine learning is type of AI technology. It can take inputs in terms of numbers, words, images, and language, and can digitally store it and then identify like patterns around it. What is generative AI? Generative AI refers to type of deep learning artificial intelligence technology that can generate new content from text to images, sounds, videos based on data that it has learned from. It also uses patterns and information from vast amounts of data to create new and similar data. This slide just shows some of the characteristics of AI, traditional machine learning, and generative AI, and then defines like the purpose and data interaction. So the AI developed computer system that can perform tasks that typically require human intelligence. Machine learning made predictions or decisions based on given data. And generative AI generates new data samples that resembles a given set of training data. And this is what are some of the data that can go into the healthcare algorithms that are in practice and used today. So in this slide, the left-hand side shows structured data, and the right-hand side shows some of the unstructured data. And in structured data, you could have data from from various sources like electronic health records, pharmacy data, claims data, and unstructured data is basically notes, reports, images, and any type of natural language data. Now, let's dig deeper into big data and AI in healthcare. So adoption of electronic health record is now widespread across in the United States. By 2021, 78% of office-based physicians and 96% of non-federal acute care hospitals adopted certified electronic health data. This widespread availability of digitized healthcare data led and paved the pathway to develop AI-based, ML-based technologies. Now, we are also seeing this trends in an excitement about using AI in healthcare delivery data through trends in FDA approvals and academic publications. So for example, by July 2022, there were about 500 medical AI systems approved by the FDA. And in the last decade, the increase in amount of publications or manuscript that feature healthcare AI or ML have increased from 3,500 to about 50,000. So now, what are some of the benefits of using AI in healthcare? So there are several benefits of using AI. Studies have shown that integrating AI into healthcare can improve operational and care delivery. One estimate suggests about $150 billion in cost savings by 2026. However, there are very few AI tools in use in care delivery setting now. So there are some challenges of AI adoption in healthcare delivery. For example, there's lack of trust in AI solutions. There's potential for bias involved through a life cycle of AI. There's absence of systematic approaches to governing and maintaining these technologies, and regulatory and compliance challenges as well. So this brings me to our next section about the overview of our Health AI partnership, which is why we got together with other health institutions who were working in the space to understand what are some of the best practices and how to address some of these challenges. So we recruited more than 22 health institutions, and the Health AI partnership started in 2022 to develop actionable guidances and best practices for safe, effective, and equitable adoption of AI in healthcare, and understand governance needed to monitor and maintain these systems. Our mission was to empower healthcare professionals to use AI effectively, safely, and equitably through community-informed, up-to-date standards. And we defined our values as we want to make sure we advance health equity, we improve patient care, and use technologies that advance patient care and not technical novelty, improve the workplace, and also make sure we build community of practitioners where we can share experiences, challenges, and learnings. These are two major outputs of Health AI partnerships work in the phase 1. First was the standard AI solution procurement milestone, which is the 8 key decision point framework, which I will go in detail in a later section. And then equity across AI lifecycle framework, which were procedures that health system leaders and developers can follow to understand impact on health equity. And my colleague Ji Young presented on HEAL framework in the previous presentation, and I think the recording is on the website. So as you can imagine, we are not the only ones convening people to think about these challenges. It is a crowded ecosystem. There are different organizations focusing on different things around AI and organizational governance, AI and best practices, and AI and standards. And we want to make, so how do we differentiate ourselves and how do we stand out from these different organizations? So we are really focused on healthcare delivery organization, and we want to make sure we understand their needs, their challenges, and surface those. We want to support high and low resource environments. We want to make sure we bring in perspectives of technical, operational, strategic, and regulatory stakeholders, and also provide technical assistance for AI implementation where needed. So now let's dig a little bit deeper into the 8 key decision point framework for AI adoption. We developed these standards for AI adoption via 2 research activities. One was design research, where we conducted design research to understand how the user what the user needs, and understand what would be immediately useful for these health system leaders for which we are building these standards. We also conducted qualitative research via interviews with practitioners to surface these standards. So this is the 8 key decision point framework, and we organize these framework around 4 stages of AI adoption. So let's go into each of the decision points. So the first decision point, which is identify and prioritize a problem, this decision point features guides for identifying and prioritizing problem within healthcare delivery organization and surfacing stakeholders affected by the problems. Also includes guides for determining different dimensions of the problem and assessing the suitability of AI as a technical approach to address the problem. This is an example of a process for sourcing problems across organization. So for example, how do we identify problem in our RFA process, right? So we start at C-suite level where the executive leadership defines the strategic priorities of the institution. And then we work to and then we announce our RFA process and solicit problems from frontline clinicians and from department leaders to address that particular strategic priority. Then there's a selection process for 8 to 10 projects. And then we, once the projects are selected, we do scoping meetings with the frontline clinicians who are championing those solutions and problems, and define and design the suited solution and help with the implementation planning for that solution once it's developed. So decision point 2, identify requirements for an AI product as a viable component of the solution. This decision point features guides for how organization can assess the feasibility and viability of adopting AI to solve problems. Also includes guide for conducting preliminary assessment of AI products, assessing risk of AI adoption, and auditing the process by which AI investments are made. So for one example is conducting comprehensive data quality assurance. This becomes bulk of the work of an AI project, honestly, where we are really digging deeper into the data, what it looks like, what are the sources of data, how do we clean it, how do we make sure that it's complete and plausible, and how do we group concepts together, and then do clinical adjudications to understand like whether this data is fit for use as features into any of the models that we are building. So a lot of this has phase 1 is data element pre-processing, where we are grouping similar entities together. Phase 2 is ML data quality assurance checks, where we are working with clinicians to like make sure that the type of data, the value, the ranges are all correct, and we are not seeing any not plausible data. And then for phase 3, we do data adjudications, where once we have the clean data, we want to make sure that the clinician looks at it and confirms that this is fit for use. So for example, this is an example of entity resolution. The image on the left shows that creatinine, for example, can be logged in electronic health record in several different ways. So we are looking at each of those creatinine labels and confirming whether this is the same concept or something else, and should, for a particular use case, should we be using this creatinine concept or not? And once we group all of the creatinine together, then it becomes fit to be used in the model. Decision point 3, develop measures of outcomes and success of the AI product. This decision point features guides for defining the scope of use, constraints, and dependencies of AI product. Also includes guides for defining technical performance targets for AI products, as well as measures of success for AI product use in practice. So for example, these are some of the categories of measures for defining performance targets for AI products. So we will define for model performance, what are some of the example metric that we have to track to make sure the model is accurate, reliable, and effective. For software performance, we will do the same. For usability, for example, we will talk to end users and understand whether their satisfaction and what are the user errors and ease of use, things like that. For business category, we will try to understand, does it result in reduction in diagnosis time or cost saving or whatever metrics that were decided? Are we meeting those metrics with the proposed solution? So for example, there are different ways of showing model performance, like traditional ways of AU ROC, AUPRC, and there are other ways where we could define sensitivity, positive predictive value, like, for example, number of alerts that you have to go through to find one patient that you're looking has a positive outcome. The fourth decision point is around design a new optimal workflow to facilitate integration. So now, once we have the model developed, this decision point features how organization can design optimal workflow for clinician-facing AI products. Also includes guides for adopting pre-existing operational structures, workflows, and technologies to enable successful integration of these products into clinical workflow. So for example, when we rolled out Sepsis Watch into Duke University Hospital System, the existing patient care workflow needed to be modified so that the model could fit in a seamless manner in the existing workflow. So for initial rollout, we established a new role called the Rapid Response Team nurse role, who would be looking at the predictions that were made by the Sepsis Watch and then acting upon those predictions. So this is just a quote from one of the RRT nurses that it's cool, it's totally new job title and a new responsibility, and I won welcome. So the point was the existing workflow didn't work for the Sepsis Watch rollout in that particular hospital. So we had to think in a creative way and work with a lot of like health system leaders, nursing leaders, nurse on the ground staff, and end users to understand how we can seamlessly fit in the workflows. But when we expanded the Sepsis Watch to regional Raleigh Hospital, the RRT workflow would not work because we were expanding into the ED and RRT did not have jurisdiction in the ED. So we had to adjust the workflow again to ensure that ED nurses were now trained up and were on board to be using Sepsis Watch, and it fit in their workflow. And then when we started expanding further into Duke Raleigh Hospital, they preferred a different workflow based on their needs. So instead of a dashboard, they wanted a pull strategy. They wanted to make sure that I don't think the nurses were, I don't think we have time to like look into a dashboard. Can you just send us a notification anytime a patient meets the Sepsis Watch notification? So then we had to adjust the workflow according to that. So now the fifth decision point, which is on evaluate safety, effectiveness, and equity concerns of the AI product in the intended setting prior to clinical use. So this decision point features guides for locally validating AI products before clinical use, and identifying foreseeable and unresolved risk resulting from the AI use in clinical care. Also includes guides for determining if AI products should be clinically integrated or abandoned. So here's an example of how this plays out. So we built a model to predict sepsis. The outcome definition included blood culture. This is pediatric sepsis. So the outcome in definition included blood cultures, antibiotics for 4 days, and acute organ dysfunction. The model had a 6-hour prediction window and 3-hour snooze window. The model was trained on 4-year data from 2016 to 2020 on about 17,000 encounters. And the model was validated on 18 months of data set on about 6,500 encounters. When we reviewed the model performance on retrospective data and temporal data set, it looked promising. So we decided to go ahead and plug in the model in the real-time data pipeline and conduct silent trial. Silent trial basically means we test the data, tested the model in real-world clinical setting, but without actually impacting patient care decisions during the trial period. So we were just like running it in a silent mode, looking at what predictions it's making, validating those predictions, but not acting on them, because we want to make sure that it's all safe and effective. So when we ran the silent trial for about 2 months on about 1,400 encounters, we were expecting maybe about 2 alarms per day based on retrospective data, training data, right? But the model ended up firing about 30 alarms per day, way more than we expected. So we had to investigate why this is happening. And we involved data scientists in our teams and statisticians to look into the data and figure out why the model was firing 30 alarms per day when we were expecting it to fire only 2. So we found it was due to something called as label leakage. The model was seeing an artifact that artificially inflated the model performance during training data due to a process called as layer normalization. We removed the layer normalization, and when we did that, the model got much worse. So not to bog you down in all these statistical terms, but the point is that we noticed that the model was actually not that good, and we ended up not deploying this model into the real world setting. So we really needed to do those silent period trial and make sure we are watching the model perform, how it performs in real life before we actually deploy it in clinical setting. So now, decision point 6, execute AI product rollout, workflow integration, communication, education, and scaling. So once we have tested the model, made sure it's safe and effective, we don't have any more concerns over it, and we've decided we will plug it in and roll it out for clinical use. So we reach the decision point 6, where the guides feature, where this decision point has guides for disseminating information about AI product to affected clinicians, managing changes in workflow environment caused by the AI product, also includes guides for preventing inappropriate use and AI product beyond their intended scope. So this here, health data is dynamic and it changes frequently over time. So this is a schema of our flexible data pipeline technology. What we learned is over time is that in order to ensure models are still relevant, and we might need to modify the model based on changes in the data inputs or changes in how the clinical outcome is defined, we needed a modular infrastructure where we could quickly update the model, test it out again, make sure we can run the silent trial on real-time data, and then plug it into clinical use. So this infrastructure allows us to make sure that we do that part well. We also built artifacts like model fact labels that mirror design of nutrition label to help communicate the details about the model and the solution in a very accessible language. We now include these with every algorithm that is integrated clinically at Duke Health. These artifacts are now becoming policy from ONC as well. So ONC, it was cited about 10 times in ONC's new rule that required transparency and algorithms integrated into EHR. So this is a great way to communicate with frontline clinicians about like what the model is about, what should we expect, what is the intended use, what is out of scope, some of the warnings and some other information like ownership of the model, who to contact and things like that. Now, once the model's out there running in the world, you hit into the life cycle management pieces of it. So the decision point 7, which is after operationalization, you have to monitor and maintain the AI product and its work environment as well. So this decision point features guides for monitoring AI solutions and effective work environments over time and sustaining improved outcomes achieved through AI use. Also include guides for conducting audits of AI products that complement ongoing monitoring and proactively identifying risks not envisioned at the time of clinical integration. So for example, this is a lot of monitoring occurs at this stage, mainly around model monitoring, solutions monitoring, and operations monitoring. So we continuously look at the data quality. We make sure that we compare performance, like what is the AUC, ROC, and all of that. We also look at the solution itself. So like together with the workflow, usage monitoring, are the nurses checking the dashboard? Are the dashboards working fine? Understand like, is it even being used? Operational monitoring, so understanding like regulatory and policy compliance issues around if anything changes in that landscape, how does that alter the solution altogether? Alerting and notification, like user interface needs and all of that, and any workflow changes needed. So this is an example. So my colleague, Mike River, has like 4 screens in his office. And when you enter his office, you can see all these graphs in different screens where he continuously monitors what happens in terms of data quality in Sepsis Watch. And we also do, like, for example, we track the outcome itself, like the outcome that we were trying to affect with the use of the model. How does that change over time? Decision point 8. So this decision point features update or decommission the AI product and workflow environment. So this decision point features guides for updating or decommissioning AI products, adapting work environments affected by AI use, and expanding the use of AI products to new settings. Also include guides for minimizing disruptions and harms that result from decommissioning AI products and disseminating information about AI products to affected clinicians. So this basically thinks about life cycle management of the AI. So once you have deployed it, it's running fine. You're monitoring the data continuously, and the model is continuously. Now, what are some of the life cycle maintenance type issues that you see throughout the life cycle of the project model? So these are buckets of various activities that happen during the maintenance phase. For example, on a continuous basis, we will look at the environment and the use of model. We will sometimes update and customize in user interface for different users. We will look at scaling strategies for different use cases or different work environments. We will conduct user testing. So staff turnover happens. Do you need to like train other end users? How frequently do you need to train? Determining ownership of the model. When does it make sense to decommission if something significantly changes in terms of clinical data or outcome features, things like that. Now, this brings us to organizational governance of AI. So we talked a lot about the decision points and adopting the AI and integrating into the practice. We took all of that learning, from Health AI Partnership, from the work that we did at DIHI, and from all the work that we, all the interviews that we did with other practitioners across the nation, and the governance processes that we underwent as part of our work at Duke to help another institution and define governance processes around AI use. So how do I, what is the difference between monitoring, which I talked a lot about in last few slides, versus governance? So monitoring ensures the safety, effectiveness, and reliability of AI application in clinical setting. So like what is the model fine, is the solution fine, and the operations fine? As I defined, the activities include continuous data quality monitoring, continuous assessment of accuracy, real-time tracking of performance. Governance is a little bit broader oversight over the development, deployment, and general use of AI. So like, is there even a need for that part, AI? What is the impact of integrating such an AI into clinical setting? What are some of the risk mitigation needed? What are some of the challenges around legal, regulatory, and ethical compliance? And a lot of activities around governance will focus around formulating policies and operationalizing those policy regularly, checking on different tools that are in use, promoting transparency, addressing ethical concerns like bias, fairness, human oversight, and such. So there's varying degrees of AI governance maturity amongst health systems. With the health systems we engage with, we try to map out where different institutions stand in the AI maturity landscape, and we created this metric where we try to map them on technological capabilities and organizational governance process. So technological capabilities, high, medium, low. What does that mean? So low is when the institution is not even using AI models or models that are in the EHR system. Medium is like fully using EHR capabilities and implementing vendor-based solutions. And high is they're building their own capabilities and user interfaces. Organizational governance processes like low, medium, high again. We try to figure out where different institutions are, because institutions are still trying to understand and develop processes and policies around AI governance. So this is what we found. So the blue dots are institutions that are developing and procuring solutions for internal use. Green is institutions commercializing. So they're developing and commercializing the internally developed solutions. And light green is institutions building solutions for internal use and also commercializing the internally developed solutions. Now, this is an example of what the governance process is followed at Duke Health. So Duke Health has the governance process is called algorithm-based clinical decision support oversight. This was set up in 2021, and it follows the framework of people, process, technology framework. So the ABCDS lifecycle consists of 4 distinct phases with evaluation checkpoints placed at each of those different phases. And they define these 5 principles. And as you pass through the different phases, you check in with the ABCDS and around these 5 principles, which define the metric that they will evaluate you under. They also follow a risk-based stratification of what AI to govern. So at Duke, all electronic algorithms that could impact patient care, including data-driven clinical consensus model and standard of care tools, fall under the ABCDS oversight. So and then that defines the risk level posed by that particular tool. So for example, a standard of care tool which is used to guide standard of care that would be supported by evidence and medical literature, poses low risk, versus data-driven model which is non-standard care tool, a model that builds relationships between input and output data using statistical machine learning techniques will fall under high risk category and will have much heavier governance oversight. So as I was mentioning, we took all of this learning and we tried to help another institution customize AI governance practices that were fit for that particular institution and that particular institutional structure. And I will, in the next few slides, I will go through what we learned from that project and what we recommended based on what we learned. So the project was composed of 2 activities. One, we conducted interviews with 12 stakeholders in a particular institution. We talked to clinical, technical, and operational leaders to analyze the current state of AI governance and to surface the needs for future AI governance. We also mapped out what a typical algorithm journey map would look like for that particular institution, to identify key stakeholders for future AI governance, and to map out processes for AI governance. This helped us formulate what is best suited recommendations for establishing governance policies that would serve the need of that institution. From the interviews, we were able to analyze the current state of AI governance. What you see here is synthesized interview findings categorized under 4 stages of AI adoption. Across the 4 stages of AI adoption, we were able to identify what institution is already good at, as well as gaps and opportunities for improvement. So the text in green is practices that the institution is already following and is good at, and the text in black is what are the opportunities which will help us define the recommendations. So for example, for procurement, we found that the institution is good at identifying problems across the organization and assessing feasibility of adoption. However, we found that there's not sufficient time and transparency for assessing the problem and solution, and there needs to be clear evidence-based reasoning of why we are adopting a particular AI tool. So this slide just shows some quotes from the interviews that we did. So for example, one of the operational leaders we are working in a lot of silos. Technical leader around procurement phase was like a lot of times the problem is not clear. We are already jumping to the solution and going to look for something to purchase with even understanding the problem. So all these insights are interconnected with socio-technical environment, and by considering them together, we can gain more comprehensive understanding of complexities and challenges of these tools getting integrated into clinical care settings. So after gathering all this information from interviews and algorithm journey in a map, we were able to develop recommendations across 4 dimensions. So we gave recommendations around people, process, technology, and operations framework. In the people dimensions, we suggested to define roles and responsibilities of key stakeholders who are responsible for implementing unified AI governance, create education and training programs for these key stakeholders. Under process, we suggested adapt, institutionalize a unified governance process for AI lifecycle management using the 8 key decision point framework, and document internal AI governance policies. Under technology, we suggest develop technical capabilities and infrastructure needed and align with the IT roadmap that they already have. And for operations, we recommend establish business plans and operations of how they will bring together these people, process, and technology infrastructure, and roll out the governance process, and also define the impact measures for the success of such governance process. So for example, for people, we recommended who should oversee the AI governance. So they already had a digital health committee. We said you should build on it and have different subcommittees for AI governance and establish roles and responsibility under those subcommittees. So this is just an example of what types of expertise domains that we recommended and what types of skills they should have and responsibilities. So for example, clinical and medical a stakeholder who has clinical and frontline knowledge, who understand patient needs, and social technical expertise around AI use in clinical setting. They can advise on clinical risk and also advise on whether this AI tool could be operationalized or not. Technical, for example, engineering and data quality, and they can help evaluate the proposed AI implementation by assessing model performance, user interface, and solution performance. Then we also recommended to define a scope of AI governance. So once you, when we start thinking about the process of AI governance, we want to make sure that we figure out, okay, what type of AI tool will fall under the governance process and what will not. And in adapting, so we recommended that all tools should be registered because they wanted to make sure that they have at least some inventory of what is being used. And then based on risk and based on the other characteristic, define how much governance and what pathway each tool will go under. So we also define documentation requirements. So safe, effective, and equitable AI adoption requires documentation of key information. This is not, so this table shows around the AI lifecycle stages, what are some of the information that should be collected, and what decision will those information help us make. This is not a comprehensive list, but some examples. So for example, under problem identification, we recommend that you should make sure that whoever is proposing a solution clearly defines the scope and intended use. And that will help you understand the risk of the tool and what governance process, what intensity of governance process it needs to go through. For example, under clinical integration, we said you should ask project teams to make sure that they conduct user feedback surveys and understand frontline clinician needs and post-integration and monitoring surveillance. And this will help you determine sustaining the use of AI solution beyond the testing phase. So this is the risk-based AI governance. So this figure, sorry.
Yes, so I'm going to interrupt you. So just very quickly, we want to leave a little bit of time for questions. So sort of summary, looking at sort of the top level takeaways, where are we at here in terms of what should clinicians and other end users sort of look at and emphasize when they're looking at a tool that they're going to integrate into their clinical practice or use for operational purposes like enhanced patient scheduling, whether they're doing a screening or using it for population health.
So in my opinion, I think the main question is like, what is the problem that tool is trying to solve, and really having a deeper understanding of whether the tool, which is a part of the solution, can actually affect the problem that is brought up. So I think the earlier topic guides in the key decision point framework focus a lot on understanding the workflow, understanding the end user needs, and understanding like how that particular technology is part of the solution and can affect the problem. So that's one main thing. The other main thing is like, what are the once the tool is integrated and working, what are some of the maintenance requirements needed? Like, and who has the ownership of that? Like, if something goes wrong, like who do you talk to, and what are the life cycle events that take place, and how brittle is it? Like, and how stable it is? Yeah.
So I think those are really key takeaways. And so although this concludes our three-part mini series within our 8-part series on healthcare AI, we are going to have some additional engagement on AI enabled interventions and applications as part of our upcoming summit. So on May 29th, there is a 3-part AI enabled series within itself as well. It's going to be covering regulatory and payment, some clinical best practices. Please register at the link provided by Mariah Getch in the chat. Due to some generous funding, we are able to offer scholarships. So please do not let the registration be a rate limiting factor on whether or not you participate. And also, as a reminder, with the next slides, I think we have some additional updates on our 2024 last in-person workshop, which will take place in July. Again, there's a registration there. These are no cost, in-depth resources if you want to implement new digital modalities in your practice, particularly if you're looking at CalAIM and Medi-Cal and enhanced care management, screening for social determinants of health. This is a great workshop to attend in order to get some very practical tips on soup to nuts on how to implement a program, all the way from change management, regulatory and payment issues, operational issues, and how to interact with a vendor. So could not be more grateful to both Dr. Sendak and Alifia for this tremendous work that you all have done, really to advance the profession and the clinical rigor of really seismic changes in healthcare delivery in the years to come. We hope to see the rest of you for our additional programming, and we hope to be doing more with the Health AI partnership in the very near future. I'd like to take this time to thank both Aislinn Taylor and Mariah Getch. Without you, we would not be able to bring this programming to all of you. They are the silent people in the background that bring it all forward. So yes, and thank you, Alifia. It was a fantastic presentation. So with that, we are going to bring it to a wrap, and we will see you again soon.